All right, let's dive right into the pathophysiology of glaucoma. Now, if you're a nursing student, this is for you. We're going to build a rock-solid mental model of what is actually happening inside the eye. The goal here is that by the end, you'll be able to literally visualize the entire process, which is exactly what you need when you're under pressure in an exam. So let's get into it. So to really get a handle on glaucoma, I want you to think about the eye like a sink. You've got a faucet that's always running, creating fluid, and you've got a drain that lets that fluid escape. In a healthy eye, it's all in perfect balance. But what happens when that drain starts to clog up? That one question, that's the key to understanding everything we're about to cover. Okay, so before we can figure out what's wrong with our clogged drain, we've got to understand how the plumbing is supposed to work in the first place, right? So let's take a look at the eye's normal, healthy pressure system when it's all running smoothly. Inside your eye, there's this constant, gentle flow of a clear fluid called aqueous humor. That's the water coming from our faucet. So first step, it's made by a little structure called the ciliary body. Step 2, it flows around the front parts of your eye, the anterior and posterior chambers, and it's delivering nutrients and keeping things healthy. And then, the final step, step 3, it drains away through a very specific channel. This whole cycle of production and drainage is what gives the eye its shape and keeps the pressure perfectly stable. Now, this structure right here, the canal of Schlemm, this is the hero of our story. This is the drain in our sink analogy. It's the final exit for all that aqueous humor. It lets the fluid get out of the eye and back into your body's main circulatory system. And as long as this little canal is working properly, the pressure inside the eye will be called intraocular pressure, or IOP. It stays constant and totally safe. So, we've seen the healthy system, right? Fluid in, fluid out. A beautiful balance. Now, let's see what happens when that drain starts to clog. This is the absolute heart of the problem in glaucoma. And here it is, put as simply as possible. More fluid is coming in than is able to get out. The faucet is still on full blast, but the drain is blocked. It's a simple imbalance, a mechanical problem. But this one issue is what kicks off a really dangerous chain of events inside the eye. And you really need to understand this domino effect. So first, the drain gets clogged, which means the fluid can't get out properly. That causes the fluid to back up, just like a sink filling with water. And the pressure inside the eye starts to build. That rise in pressure is what we call increased intraocular pressure, or IOP. And here's the real danger. That pressure starts pushing on the delicate optic nerve at the back of the eye. It gets compressed, it gets damaged. And because that nerve is what sends pictures to your brain, that damage means permanent, irreversible vision loss. Now, it's important to know that not all clogs are the same. In glaucoma, there are two main ways the drain can fail, and they look very, very different to a patient. We call them open-angle and closed-angle glaucoma. They're two totally different paths. But unfortunately, they both lead to the same destination, damage to the optic nerve. And this slide lays out the difference perfectly. On the left, you've got primary open-angle glaucoma, POAG. This is the most common kind. The drain is technically open, but it's clogged up down the line. Think of it like a slow, gunked-up pipe. It happens slowly, it's painless, and it gradually creates tunnel vision. But on the right, primary angle closure glaucoma, PACG, this is a whole different beast. This is a true emergency. Here, the iris physically slams shut and blocks the outflow. It's like someone just jammed a stopper in the drain. The onset is sudden, with intense pain, blurry vision, and halos around lights. For any exam, knowing this difference is absolutely critical. Okay, so we know the why behind it, but how do we actually spot it in a real person? Let's switch gears and focus on the clinical side of things, what you as a nurse would be assessing, and what numbers we're looking for to make a diagnosis. This number, burn it into your memory. Normal pressure inside the eye is between 10 and 21 millimeters of mercury. Anything above that range, that's a major red flag for glaucoma. This pressure reading is one of the most important tools we have for finding and managing the disease. I want to pause here for a second because this is a classic exam question just waiting to happen. Acute angle closure glaucoma is not a wait and see kind of thing. It is a true medical emergency. That sudden, awful eye pain, which can be so bad it causes nausea and vomiting, it needs immediate action to save that person's sight. You see these symptoms, you think PEG, and you act fast. So if the problem is a clogged drain causing high pressure, then the solution has to be about fixing that plumbing issue, right?
Exactly. Every single glaucoma treatment, whether it's medication or surgery, is designed to do one of two things: either turn down the faucet or unclog the drain.
Let's start with the medications. Some, like miotics, work by making the pupils smaller, which actually helps pull the iris away from the drainage channels, basically helping to open up the drain. Then you have others, like carbonic anhydrase inhibitors and beta blockers, and they work by turning down the faucet. They reduce how much aqueous humor is being made in the first place. See? The goal is always the same. Get that balance back between inflow and outflow to get the pressure down. But what if meds aren't enough? Well, that's when you might need surgery. A trabeculectomy is kind of like calling in a master plumber. The surgeon literally creates a brand new drainage path for the fluid. This new opening lets the fluid bypass the old clogged drain and escape, which brings that intraocular pressure down and saves the optic nerve from any more damage. So let's end with this last critical question. We've walked through the whole domino effect, right? From a simple fluid problem all the way to permanent nerve damage. And we have treatments to lower the pressure, but we have absolutely nothing that can reverse blindness once it happens. So what does that tell you is the single most important factor? It's that with glaucoma, the clock is always ticking. Early detection and lifelong management, they're not just a good idea, they are the only way to prevent blindness. And that, right there, is the ultimate takeaway.